One.
Hey, everybody. Thank you so much for joining us tonight. This is our first happy hour of the academic year for the ASMBS Bariatric Surgery Training Committee. And I'm just going to share my little intro slides right quick. My name is Laura Fisher. Dr. Julianne Lloyd and I co-host these sessions, and we alternate between a monthly journal club and a video session, always on the last Thursday of the month at 7 p.m. Central, 8 p.m. Eastern. And so thank you so much for joining us. Before we get started, I just want to mention that we have a fellow project webinar on the first Friday of each month, and we encourage all of the bariatric fellows to attend. We cover all of the didactic topics that you need to fulfill your requirements to get your bariatric certification at the end of your fellow year. And that is from 7 a.m. to at 7 a.m. Eastern time, and then a second run through at noon Pacific time. Tonight we are going to be talking about, let me go back to my PowerPoint if I can. We are going to be talking about surgical training. Our authors, or our lead author tonight, is Dr. Mattar, who really needs no introduction. He is a professor and he's the chair of metabolic and bariatric surgery at Baylor College of Medicine. He is a past president of ASMBS and is on the board of directors of the American Board of Obesity Medicine, amongst many other accolades. He did his medical training in Cairo, and then did his surgical residency at Vanderbilt and his fellowship at Emory with one of my mentors as well. And then I had the pleasure of training with Dr. Mattar at Oregon Health and Science University in 2016. So thank you so much for joining us, Dr. Mattar, and he is the lead author on our paper, which is General Surgery Residency Inadequately Prepares Trainees for Fellowship, Results of a Survey of Fellowship Program Directors. And our presenting fellow tonight is Dr. Amrita Pandit, and she is an advanced MIS, Bariatrics, and Robotics and Research Fellow at Cedars-Sinai. Let's see. I think I just lost my little cheat sheet here. Okay, so she did her medical training at the Jawaharlal Nehru Medical College in India, and then completed her general surgery residency at the University of Vermont. She was an acute care trauma and general surgeon for about 6 years, and then decided to pursue additional fellowship training and is now a current fellow. So without further ado, again, thanks everybody for joining. Dr. Pandit is going to present our paper, and then we will open it up for a lively discussion.
Thank you for that, Dr. Fisher. Appreciate that. So yeah, I decided to take a little pivot to expand my skill set to bariatric surgery, and that's why I'm doing this fellowship at Cedars. I'm sorry if you hear some background noise, that my kids running around. I try to keep them quiet, but it's hard. So let me start this presentation. The first paper we are going to talk about, as we said, is the general surgery residency inadequately prepares trainees for fellowship. This was from Annals of Surgery in 2013, and we have our esteemed author here today, so we'll have great discussion at the end. As we all know, surgical landscape is rapidly evolving with new technologies coming in every few months. new staplers, robot like has been up and about pretty much every corner of training these days that people want to get in. The integration of advanced minimally invasive techniques and exponential expansion of variety of procedures can also be overwhelming, as we know. There are limitations in our training programs and safeguards imposed by regulatory bodies, namely ACGME, with strict adherence to duty hours. And there is enhanced level of supervision that is required by the programs, which also in turn decreases the autonomy for our residents coming out of their residency. So more than 80% of the chief residents who graduate proceed to 1 or 2 year fellowship in varying specialties. Um, a recent survey of surgical residents has revealed that nearly 40% of residents lack confidence in their skills after 5 years of training, including 23% of the graduating chief residents. And because of that, ACGME has designed all fellowships, multiple fellowships. The Fellowship Council itself was established in 1967, a little bit of a history there. And it has a committee on there which constitutes of 9 members from different component societies. The objective of this study was to assess the readiness of general surgery graduate trainees entering into the accredited surgical subspecialty fellowships in North America. 3 electronic mailings were completed over 2 weeks over the period of 6 weeks, and the survey was sent out from month of April to May of 2012. The design was as such where they wanted to look at the professionalism, level of independence, graduate responsibility, psychomotor ability, clinical evaluation and management, as well as academia and scholarship. And the responses were noted on the Likert scale from strongly agree to strongly disagree, as you see there. Psychomotor obviously had 4 options of strongly agree, disagree, agree, or strongly agree, where there was no neutral. The results were as follows. They had total of 145 surveys sent out of which 91 responded. So the total rate of 63%. The PD's opinion were as follows. 21% felt that the new fellows arrived unprepared for the operating room, and 38% demonstrated a lack of patient ownership. 30% could not independently perform a laparoscopic cholecystectomy. 66% were deemed unable to operate for 30 unsupervised minutes of the major procedure. For laparoscopic skills, 30% could not atraumatically manipulate tissue, and 26% could not recognize anatomical planes, and 56% could not suture. Those are pretty impressive numbers. Furthermore, 28% of fellows were not familiar with the therapeutic options, and 24% were unable to recognize any early signs of complications. Finally, it was felt that majority of the new fellows were unable to conceive, design, and conduct research or academic projects. Thematic clustering of qualitative data revealed deficits of operating autonomy, progressive responsibility, longitudinal follow-up, and scholarly focus for after general surgery education. But it's not all bad, okay? It's not all doom and gloom. So 82% of fellowship directors agreed that fellows were able to perform advanced cases independently by the completion of fellowship. And 89% agreed that the fellows were able to practice independently by the completion of fellowship training. So overall, the results were as follows. Professionalism, 38% did lack ownership, as we mentioned before. 38%, sorry, level of independence, lack of patient ownership and independence during residency, delays progress during fellowship, that was 36%. Psychomotor ability, foundational skills were deficient on arrival in 32%. And clinical evaluation and management, that the fellow lacks confidence in managing complex and sick patient, was seen in 27%. And academic, as you see, 69% lacked general pursuits in academics. There were limitations, like every study does have, to this study as well. This was survey based, so It is more of a subjective opinion of the responders. Only Fellowship Council, Fellowship Program Directors were enrolled. Since this was done later in the year, there is a recall bias that you can understand that the program directors might have, comparing them based on what happened earlier in the year. There is a responder bias. Not everybody responded. As you see that the response rate was 63, which is pretty good actually, but still not 100%. The anonymous nature of the survey made it not possible to compare those, demographics of who completed the survey and who didn't. So, well, what to do is the question. We know the issues. Fortunately, as you know, Dr. Mattar is one of the Blue Ribbon Committee members, and the goal-oriented specialty tracks, to be incorporated, modular teaching, and research modules and subspecialty, the availability of focused subspecialization to be adopted was the goal of this committee. They did establish transition to practice program. At this time, when the paper was published in 2013, they had 5 transition to practice programs in place. And the goal there was to not as a fellow, this person who would be taking on this position, but as a junior attending, to try to gear the goal of the individual towards his practice focus for future was essentially the goal of this transition to practice program. Then there is general evaluation of milestones that's incorporated in general surgery residency, which was actually something that I went through myself, so I know about that for sure. Focused assessment for last 3 years, assignments for the last 3 years. What this means is, if you know where you are heading, try to give maybe up to not more than 6 months of your training dedicated to that. So if you're planning to go into MIS for at least 2 consecutive years, maybe do that, do more focused assignments to cases and such in those fields. And then definitely Fellowship Council has made an effort to do an earlier match where the process of application starts in 3rd year, and by 4th year you know where you're going, so you can again target your assignments and goal accordingly and work accordingly, so you're better prepared when you go into the fellowship. In conclusion, the findings presented provide the affirmation of the concerns expressed in more general terms by the stakeholders regarding the lack of readiness of graduates of general surgery residency training to enter independent general surgery practice, or to fully form a postgrad specialty training. So it is hoped that through all the different implementations of the gap, to mitigate those issues, that we will prepare better surgical residents coming out into fellowship. So that's the first paper. Do you want me to keep going with the second one, and then discuss this at the end, or how do you want to do this, Dr. Fisher?
I don't know. What do you think, Julianne? Do you want to talk about this now and then move into EPAs a little later?
Yeah, we can talk about this because, I mean, even though I read the paper as I was watching your presentation, it is a little depressing. It makes me think that we are just not qualified. And it also makes me wonder, oh, sorry, I should let Dr. Mattar comment, but I'll just finish this point. How all of this information compares if you were to ask the program directors from residency, if the data would align with what the fellowship program director is saying. But Dr. Mattar, you have the floor.
Yeah.
Oh, thank you very much. And thank you for inviting me. I really love what you do, especially the service that you provide for all the fellows. It really resonates with me a lot because I've spent a lot of time training fellows and being part of the Fellowship Council. I think there are some important points that we need to take into consideration when we read this paper. It is 10 years old. And a lot has happened since then. At the time, this created quite a stir. In fact, you know, I don't know, I must have written 60, 70, 80 papers on MIS and bariatric surgery. And this is the one paper that brings me the most infamy. It's the only paper I ever wrote about surgical education. And the background or the genesis was that, you know, we'd have all these meetings at the fellowship council and everybody would say, what's up with these residents? And so we thought maybe because we were in academic centers mostly and so on, we thought that it just pertained to us, but we did want to see like what the landscape looked like. And this is what generated the survey at the time. And frankly, we were all surprised by the results that we got. Just some points of clarification. The Fellowship Council was conceived in 1997, not 67. And it really came about because it was at the time of the start of the laparoscopic revolution, if you will. And so there was a lot of high demand to train in this area. And this is how fellowships started. If you remember, you probably don't know this, but at the time, a lot of surgeons were being trained on weekend specials. So they would go to a course to a city, spend a day on pigs, and then another day observing surgeons, and then go home and start operating. And of course, there were issues with that. So the Fellowship Council started standardizing curricula, but we found that the fellows that were coming in were struggling to really gain autonomy and independence because they were still having to learn a lot of the basic principles of laparoscopy. And this is what generated the survey. However, you know, although it met a lot of criticism especially from the ACGME people, I remember well, because they felt that they were being, you know, challenged or accused in certain ways. But it did stimulate the whole advent of EPAs. And I think it's one of the elements that came about that created or caused an alarm bell to ring and say, hey, we got to change something about the way we're training these residents because they're obviously not ready for the market. And I think that EPAs will probably address many of these issues because you won't sign off on residents until you feel that they are entrustable for, you know, in specific areas. So once again, thank you very much. And I'll be happy to answer any questions you might have.
I have a question for you, Dr. Mattar.
Yeah.
If you see now with especially bigger centers, they are so focused on robotics that laparoscopy and open surgeries are behind. I heard a third-year resident say, I mean, he almost finishing third year, going into fourth, that he has not seen, I mean it, not seen a laparoscopic cholecystectomy since he started the residency. So he wanted to go and, you know, join a surgeon and watch this because this was, so I think we have advanced, but my feeling is it's another realm right now where you're going to fight the same things. The other day I was in the you know, surgical lounge, and the nurses, I eavesdropped, but you know, talking that how a urology surgeon got into a complication, opened up the belly and didn't know what to do. Because so I think, yes, you will see better maybe, you know, things, but you know, you will only assess them what you do at your place, which is robotic, you know, bigger centers I'm talking about. And then what about when you have an issue like this, then how is how is this EPA or anything as such going to help us?
Yeah, I hear you, and I have the same concerns. I share them. I also heard, I can't remember if it was a resident or an actual, a graduated practicing surgeon who said that they would go, if they had trouble doing a robotic procedure, they would go straight to opening the patient without trying a laparoscopy first. But you bring up a lot of points. It's been a decade now since this paper came out. And I think it's probably timely that we repeat this exercise again. Let's resurvey current program directors at this time, at the same time, survey residents. Actually, no, survey fellows to see if the program directors' opinions of their fellows correlate with how the fellows are feeling about where they are. There will obviously be a discrepancy. I think I'm going to take that to the Fellowship Council. I still have a little bit of influence there, and see if they would be willing to conduct the survey again and see where we are compared to before.
Yeah.
And I'm hoping we've come a long way since then.
That was going to be one of my comments, Dr. Mattar, is, when we read this and I think about the fact that it's 10 years old, I picked it because it was a paper that everyone was talking about, and it came out right before I matched. And everybody was like, oh, you matched with Samar Mattar. Did you read his paper? And I was like, no, what paper? And then I looked it up and I was like, oh God, I'm going to go train with the person who thinks I'm inadequately prepared. Oh no.
You're an outlier, Laura.
It was good motivation to practice before I came to fellowship. But I wonder, I do wonder how much progress have we made? Everyone, there's always like the kind of sense of the younger generation, like what are the kids listening to in music these days? Their music sounds terrible, and each generation thinks that of the one below. So I wonder how much of it is that. And then I also wonder, when we're trying to think about surgical education, we keep expanding the list of things that we are expected to be experts at, but we really haven't expanded how much time we allot to that education. And, 20, 30 years ago, surgical education was entirely open. And then we added laparoscopy. And now we have robotics and endoscopy as well. And so each one of those things is an entirely separate skill set. And there's a lot of overlap in terms of some of the decision making, but it's really become much more complex than it was, 20 years ago. And I think additionally, the 80-hour, work hour regulations kind of somewhat probably feed into this as well, in terms of, how do we get adequate training with less time? But those are all some of the, and I don't have answers for any of these things, but those are some of the questions that come up when I think of this paper.
And let's keep in mind, it's not just the psychomotor domain. I mean, we've been talking about that a lot, but there are another 4 domains, including professionalism, scholarly activities, all these other things that I'd be very interested in knowing how we've progressed since then, and whether residents take more ownership of their patients, or are they more leaning towards shift mentality. Not that it's good or bad. It would be just nice to get a snapshot of how they feel about that, and whether they are still as creative and innovative as in the old days or not. Maybe it's not that important anymore, but these are all domains that I think I'd be very interested in knowing how they've progressed.
Mm-hmm. And really, I do think that this paper helped to stimulate the discussion that led to the idea and the development of entrustable professional activities as a way to gauge development and proficiency, as opposed to, the opinion of the person teaching. Mm-hmm. On a written survey done 2 months later. but those are really just now coming into effect. And so one of the questions in our Q&A is, there has been some talk about surgical residencies moving to allowing people to graduate only when they've been labeled, proficient in X number of things, as opposed to a certain amount of time. Do you guys have any thoughts, opinions on that? Feasibility, good idea, great idea, bad idea? I don't know.
See, that probably, years ago when they used to have pyramid system, and people kind of some people took disadvantage of that. So hopefully it doesn't come to that. Like, not as long as it's not just one person deciding your fate, I think that would be more of a sustainable thing and probably a better outcome than otherwise. So I think that's my thought, like just
Yeah, I really like the idea of it, because I think it allows us to standardize training a little bit better. And especially now with the introduction of AI, we were talking about this earlier in our group meeting. I think that opens a whole new arena for us to assess, I guess this is more technical, but proficiency and mastery of some of the technical skills. So I'm super excited about it. I think this is great. It's probably going to take us a long time to adapt some of these things into practice. But I would imagine probably in the next 10 years, this is going to be very standard for us. And I think it will be good for patients too.
I think the logistics are going to be really hard because our entire system is based on a time period, and rotations and coverage and all of that kind of stuff. So changing it to be based on it takes as long as it takes for you to become proficient. And that might be 1 week or it might be 30 weeks. I don't know, that is going to be really, really challenging. And I'm not sure.
But I think, Laura, that some of the skills are transferable across rotations, right? So it may not necessarily be that you have to learn how to do a particular, I don't know, like how to dissect out the triangle of color, right? But maybe it's that you have to figure out how to manage a difficult patient, and that can be possible in vascular, it can be possible in cardiac, it can be possible in HPV. So I think it depends on the type of domains that we're looking at. But I think there's a ton of potential here.
I agree. That's a good point.
Yeah.
Should we go ahead, Dr. Mattar?
What are your thoughts on video-based assessments?
Yeah.
Do you think that could be incorporated into objectively assessing residents' proficiencies and skills?
Absolutely. Yeah. And I have to say, I guess at this point, the fellows are not so much worried about this, but I remember when I was going through the job search, I actually had some people ask me to send them videos of me operating. Yeah. And it made me wonder if this was going to be the new standard, right? So as you finish residency, are you now going to have, you have your knowledge assessments, you have your clinical assessment, like the certification exam. And then now are we actually going to also have a video-based assessment? So, I see something like this happening on the horizon.
Yeah. And I think it's interesting because the video-based assessments has definitely arisen from minimally invasive surgery, because we like our videos. But I think it can be applied to open surgery as well, especially with all of the inline cameras now and the newer ORs. I think it would definitely be transferable to open procedures. Should we move on and talk about our EPA paper, and then we can continue our discussion? Because
I think there was another question in here. I'm not sure which one you looked at. Did you guys talk about the 3+3 model?
Not yet. Yeah.
So there's a question from Ali Kovar. She's wondering whether we should streamline residency training so it can be more of a specialized one where you'll do 3 years of general surgery and then you do 3 years of what area of specialty you're interested in, very similar to the integrated programs like in cardiac.
Yeah, this is one of the recommendations that we made in the paper. In the discussion, we talked about how, the fact that we now match the fellows in their 4th year gives them the opportunity to tailor the remaining of their residency and gear it towards the MIS fellowship or whatever kind of subspecialty they want to go into. And there's nothing really to stop us from extending that to even 2 years or 3 years. So I know there are some models that are being tried where there is early specialization, as Ali here mentions, in vascular and thoracic surgery, and plastics. So,
I would probably be a little bit on the devil's advocate side for this, because I personally really loved doing all of the different 4th and 5th year rotations. And I think that they all added to who I am as a surgeon now. And I wouldn't want to give that up. And the other point I would make is that I also changed my mind a lot about what I wanted to do. And I came to MIS and bariatrics pretty late. It was in 4th year that I decided that I was going to apply to this fellowship. And so if it was a much earlier match, like in 2nd year, I would not have applied, and I would probably be a very sad and tired vascular surgeon right now.
Yeah, I would agree to Dr. Fisher, because, I right out of residency, I was pretty comfortable taking on ACS trauma surgery job at a level 1 center. And most of my experience for that came from PGY 4 and 5. And it was a pretty robust training. It was a community hospital, but, it was pretty good, I would say, training wise, that I felt comfortable without a need to do additional fellowship at that time. So if I were not to do that, I don't think, just like Dr. Fisher, I would be who I am today. So yeah, I think it adds to your experience and training and knowledge.
I mean, it's hard. There's definitely good arguments for streamlining training for sure, because our training already takes a really long time. And do I really need to learn about, I don't know, a bunch of stuff that I don't do now? Maybe not. So, but it's hard, right? And you say, like, I wouldn't be the same surgeon. Okay, but maybe I would be better in a different way. Who knows?
Who knows?
Yeah, so there's no way to turn back time and take a different path. So I don't know. I mean, it's definitely something that is going to continue to be discussed, and is certainly probably going to be pushed for, I would guess, just because of the time investment. But my other argument is for example, gynecology used to be a subspecialty of general surgery. And at, I don't know what year it was taken away from general surgery and added to obstetrics. But, ever since then, now we all, are very sad that our gynecology colleagues do not get surgical training as they should. And then they have to go do these really long additional fellowships for surgical subspecialties in gynecology. And I think you could potentially get into a situation where, you're training vascular surgeons who don't know how to touch the bowel, or you're training, colon surgeons who have never done trauma, or you're training trauma surgeons who don't know how to take care of the colon, for example. So I do think that some amount of more high level cross training is really important, not just doing the intern rotations, and writing all the notes and stuff. So for what it's worth.
I think you made a really strong point before, Laura. I feel like there's so much of our training that is expected to happen in a stagnant period of time in 5 years, right? Like that has not changed. And I mean, we've been talking primarily about patient care, but there's still a ton of stuff, right? So, I mean, I mentioned before about the job search, who actually teaches us about that? Managing a practice or building a practice. We're not learning any of those non-tangible things during training too. So, I mean, there's just a lot to cover in a relatively short period of time. I probably would be in favor of shortening the training a little bit, maybe not going to the 3+3, but maybe doing, I don't know, 3+2 or something a little different. But I feel like a lot of it you still have to pick up as a junior attending, regardless of what field you end up going into.
Should we run
Yes,
through the
absolutely.
paper? Awesome. Yeah, I'm excited. I like talking about education because it is a very interesting and challenging topic.
Am I still sharing my screen?
No,
Okay. Couldn't tell.
it is hard to tell when you're a panelist.
Yeah. Let's try that.
Now you are sharing.
Okay. Now it's good. Yeah.
Yes.
Good. So the next one is implementation of Entrustable Professional Activities, EPAs, into Fellowship Council accredited programs, a pilot project. This is pretty new. This was published in April of 2023, surgical endoscopy. Doesn't want to, and it's still doing that. Hold on. Okay. So 23% of graduating chief residents report not feeling prepared to work independently, increasing specialization, work hour restrictions. So kind of the same theme as we saw 10 years ago, as you see here, decreased autonomy, increasing public demands for transparency and concerns for the patient safety have fueled the drive away from a time-based to competency-based framework. Competency-based medical education is seen as an answer to these challenges. CBME emphasizes the ability of trainees, greater learning centeredness, and increased engagement in their own training. The objective of this paper was that the Fellowship Council is transitioning to a competency-based medical education model, including the introduction of EPAs for training and assessment fellows. And the study describes the implementation process employed by the Fellowship Council during the 10-month project, pilot project, and presents data regarding feasibility and the perceived value of the same. So what are EPAs? EPAs are defined and provide a practical and intuitive way to assess competency based on the level of supervision. They are observable workplace behaviors of fellow at increasing levels of entrustment from critical deficiency to ready to independent practice mode. They do not evaluate knowledge, skills, and attitudes in isolation, but rather evaluate the integration of these milestones at the point of care. They are also used to provide frequent microassessment across multiple clinical contexts and conditions, allowing for broader picture of fellows' performance compared to the quarterly assessments used currently. So the methods included a coordinated development of EPAs in collaboration with all various departments, as you see here, bariatrics, foreguts, endoscopy, and HPB fellowships. The key competencies that were evaluated were preoperative, intraoperative, and postoperative phases. 15 accredited fellowship programs participated in this project. The assessment was collected through a unique platform on the Fellowship Council website. Programs were asked to convene a CCC, a Clinical Competency Committee, on a quarterly basis. The pilot group met monthly to support and improve the process, and an exit survey was evaluated that perceived the value of, was performed to perceive the value of EPAs. So minimum required EPAs by the fellowship categories, as you see, are here, where you see on the left the fellowship category and the score set required for each one of those. These are the different entrustment levels of a fellow from level 0 to level 4, where 0 is deficient fellow and only trusted to observe, whereas level 4 is practice ready, where without a supervision, you can trust the fellow, but there is the availability of oversight as needed. EPA assessment platform was through via SMS and email, initiated via a fellow or faculty. And it was 1 to 3, it takes 1 to 3 minutes to complete, and is once initiated is available for 72 hours. Then the clinical competency committee, which is formed by at least 3 members, including a faculty, program director, and APD, but definitely should include another faculty, is on there. And then the pilot project consisted of 8 Zoom meetings, which were conducted through September of 2020 through June of 2021, which was initially more geared towards if they know how to access these EPAs, or if there are any issues they're encountering in completing them. And later on in the year, they focused more at the rate of completion once they knew the enrolled fellows and the faculty knew how to access them. The other goal they were looking at was the feasibility, and that what that meant was the goal of each fellow was to perform in order to evaluate them for EPA was to make sure that they're at least performing more than 50% of the case, and then evaluate the progress over time. And eventually they performed the survey as mentioned. So results, there were 15 participating programs, 18 fellows, and 106 faculty members. A total of 655 assessments were initiated with 65% completion rate. The average from each fellow was that the EPAs were completed was 24, and ranged 0 to 72. So that's a pretty wide range, but average was 24. Intraoperatively, EPAs were preferentially completed, that was 71%. The average time for both fellow and faculty to complete an EPA was 27 hours. Engagement increased from 39% of fellows completing at least one EPA in September to 72% in December, and then declining again to 50% in May. The entrustment level increased from 6% of EPAs at the beginning to, that was in September, to practice ready in June to 75%. So that was good. The exit survey was returned by 63% of faculty and 72% of fellows overall. 46% of fellows and 74% of program directors recommended full-scale implementation of the framework. But fellows, 7 out of 13, 54% thought this was an added burden to their workload, and they did not feel that EPAs improved their confidence in their ability to start practice, in contrast to attendings who felt that EPAs were useful in determining if fellows were ready for independent practice. So in conclusion, a competency-based assessment framework was developed by Fellowship Council and piloted in several programs. Participation was variable and required ongoing strategies to address barriers. The pilot project has prepared the Fellowship Council to introduce CBME all across the Fellowship Council training programs. And that was that.
I'd love to get your thoughts, Dr. Mattar, on this very recent paper that has come out of your original work.
Yeah, and I remember co-authoring this paper, and at the time I was surprised by the variability in filling out the EPAs. Although it takes just a second to do, well, not a second, it takes about a minute to do, really, if you do it. And the idea is that you should do it immediately when asked, meaning immediately after a patient encounter with a fellow or immediately after finishing a case, so that you can have a valid recall of what went on. And there were some programs in the pilot study that were very high in response rates and others that were near zero. And we tried to better understand what the reason was for this variability. And it was just, the usual things, lack of ownership or lack of subscription to it, or lack of maybe acceptance of the importance of the work that they were doing, or simply that they just didn't have the time or the ability to do it. But it's interesting, isn't it, that 63% seems to be a magic number, because it's 63% of program directors, again, who responded to the survey this time, same as before, and mostly advocating for the EPAs. We have not, I keep telling Julie that we're going to start a fellowship, and I haven't gotten around to doing that, but I'm sure I would welcome using the EPAs in my assessment of the fellows. I think it would be very helpful, because it would give you a in the moment assessment. And these micro assessments, I think, it's like steering a car, around a very sharp curve. You want to take small adjustments of the steering wheel. And I think the same pertains to training fellows.
What do you think about the numbers that 75% were practice ready at the end of this paper?
Yeah, and
versus,
it's exactly
versus the 82% in your paper 10 years ago.
Right, so it's very
Worse.
similar. It's sort of validating what we wrote 10 years ago, in that the fellows come in at deficient levels of proficiency, as expected now. But the positive thing in all this is that the fellowships are working, that we are producing fellows towards the end of the year that are market ready, that are practice ready to get out there and do their good work. So it again validates and affirms the need for fellowships, because, and I'll tell you from my personal experience, I don't know about you, Laura, but my fellowship year was probably the most important one in all my training. And you learn things there that you carry on with you.
Yeah, 100%. And I never would have even expected to learn everything I learned in my fellowship year. It is really amazing. And looking back, I mean, I went from 0 to 60 in 12 months, and it was, I never would have thought it. So I do think that fellowship is extremely valuable. It's interesting, there was so much criticism about residents, quote unquote, being inadequately prepared, but maybe that's the wrong expectation. Maybe they should be adequately prepared if they're going to be doing specialty surgery.
I think the term inadequate is probably not pertinent here, because they are adequate. They're actually adequately trained for what they're being trained to do. It's the whole, the problem is that the system as it is, and the mentors that they have, the trainers that they have, are not really focused on how they're going to perform in a fellowship year. Whereas the program directors of these fellowships are always comparing the new incomers who are onboarding a fellowship with the ones that just graduated. And we see this every July, right? So maybe
you get used to having your fellows do everything, and then you have all the new ones, you have to train them all over again. I'm just kidding. I don't have fellows, so I get to do this every 2 months with my PGY5s, where at the end I'm like, I don't even know what's happening. Just do your thing. And then at the beginning I'm like, okay, got to be there before we get started, so that I can, direct the placement of where the light cord goes.
So I agree with what you were saying, Sama, before about, making sure that people are adequately trained when they finish with residency, and, they're right where they're supposed to be, because they're about to do a fellowship, which will give them even more opportunity to get better. But I would argue against that and play devil's advocate, right? Because there's still a large number of people who are graduating from residency and going straight into practice, right? Especially into rural practices where they're expected to do all of these operations that, somebody who specializes doesn't, right? So there are still general surgeons who are doing a ton of colorectal cases. They're putting in ports and doing some vascular stuff like vein stripping, stuff I haven't even thought about in a long time. So, I mean, I think as it stands now, we still have a responsibility to make sure that people who are graduating from residency really know how to operate and can be independent.
Absolutely, and they may be self-selecting, as you know, 80% of residents go into fellowships. It could be that the remaining 20 feel that they personally feel ready to embark on a career in a rural area.
I'd love to get your thoughts, Dr. Pandit, on this, considering your background where you didn't initially do a fellowship and you worked in acute care, general surgery, trauma for quite a while, and now you've decided to go back. I'd love to get your thoughts on, that
so-
experience in our training paradigm.
I thought it was funny, because I was one of the very few residents graduating from my program who was not going into fellowship. And that was like, why was a big question. And then my program director was like, oh, okay. But I had a very good mentor. And, that time transition to practice, like I would see every day, ads posted, you go on APDS, you're looking for jobs, you're looking at this, and it would say transition to practice program. But my mentor, he has passed away since, Dr. Gordon, he was at Danbury Hospital, and I asked him, what does he think? He told me, I think you are ready. I asked him, what do you think? Should I do transition to practice? He's like, well, if you want to work for free, just come and work for me. So, he's like, I think you should go and do it. So that was encouraging for me personally. And, I do 5 years, 7 years. I think you do 10 years when you're doing ACS trauma. I don't think anything can prepare you for everything and that walks through the door. There will be still something that you have never seen or done before after your 7 years, 8 years of training. And fortunately, I think the goal when you go, if you decide not to do a fellowship, my advice would be, don't be shy to call your partners. And just know your limits, know what you can do really well, know what not to embark upon, and it's okay to say no. Like, I don't know is a right answer sometimes, or I need help, can you help me? And most times, your partners, if you're working at a decent place, you will find help. And I worked at a level 1 trauma center, and I was fortunate that I would almost always have a backup, if I needed somebody. Sometimes I was that backup to my partner. So I think you will learn as you grow is the key. And now going back to fellowship, that was a decision because this is just so that this is not through fellowship council. It's off. It's not through a fellowship council. It was off cycle. So I started fellowship last year, in December. But the goal was to expand my skill set. And this day and age, you don't really get credentialed until you have certain numbers, and it's not like olden days where you go get along and just figure it out. It's not a weekend course. I thought, like, bariatric surgery, there's so much to it. So I was willing to take that step back and give up my income and move across the country, leave my family behind, all the crazy stuff, and do this because I wanted to do it. And if you feel that is going to make you happy, that's fine. And I will be honest, my laparoscopic skills for suturing sucked. Like, everything else was fine. But when I started this, because I was doing ACS trauma and, for so long that I didn't really need to do an endoscopic or endo suturing, intracorporeal suturing. I did probably twice in the last 5 years, but I was nowhere close to it. So yeah, I had to relearn it. I'm FLS certified, but that means nothing when you're translating it to, again, real life scenario. So yes, I had to redo things. So I was probably amongst those 56% who didn't know how to do intracorporeal not time. But
Yeah.
it's a learnable thing. You can teach yourself if you're just willing to do it. So yeah, fellowship has its role. There's no question about it. The question is, what do you want to do? What are your life choices and what fits best for you is the question.
Yeah, I mean, I do a lot of global surgery education in low-income countries, and this is always a question, and it's the same question, is like, if you are in a low resource setting and there's no one else around, how do you do safe surgery, and how do you make these decisions, and how do you know what your limits are? And it applies no matter where you are on the spectrum of training, whether you're a beginner or whether you're an expert, you're always going to have limits. And I think the most important thing is learning how to know what you don't know, and having humility, and knowing when you need help, and knowing that you can call colleagues, and all of the rest of it, falls into place. If those basic
Yeah,
things.
you're absolutely right. But I worked at level 1, but I've also worked at a very small place, 16-bed hospital, and I was the only general surgeon there. So I had to make those choices. I was that person, and I had no backup. I have had a complication where I'm like, oh my God, I didn't expect this, right? Like it comes out of nowhere. And then what to do? Like but you plan your cases to the best of your ability. But I think that's part of growing as a surgeon too. And no training program is going to be able to teach you that. And I think it just comes with an experience.
You can't gain personal 30 plus
Yes,
of experience in 5 years.
exactly.
You can listen to other people and what their experience is, but the lived experience, it just takes time. So
Right, right. So I think I'm very happy with all my choices so far.
there's a good comment in here from Mark Neff about how there has been a change in general surgery residencies away from having, surgeon educators, and having more, employment, hospital employed surgeons and things like that. And I do think that's another very important point, is that we don't teach ourselves how to teach. Like, education is actually a skill, and it's a learnable skill, but it's not something that we're born with. And learning how to teach in the OR is actually very challenging, and teaching laparoscopic surgery in particular is very challenging. And I have had to learn how to talk through my thoughts out loud in the OR over years and years and years. And so I think that that's probably an area that we haven't talked about enough, is giving training to the trainers so that we can provide more effective education in shorter periods of time.
One funny thing I want to mention, I was doing interviews for the residents while I was while I was professor at this other place before I started at Cedars. The medical student who was interviewing for the residency, she asked me, so what fellowship trained are you? And I wasn't at that time. I'm like, none. She's like, so how is that going for you? I'm like, that's a wrong question to ask to person you're interviewing. But I'm like, just fine. She was so appalled that how can there be a surgeon with no fellowship with the trend, But I'm like, it's possible. Just, it's possible. That was the thing I just wanted to relay. Like, it's possible as long as you know what you want.
Awesome. Well, it is 8:00, so I think we can wrap it up. Julianne, do you have any announcements?
Sure. So just to reiterate, we have the fellow project on Friday. It's the first Friday at 7 a.m. Eastern time and 2 p.m. or is it 3 p.m.? Sorry, 3 p.m. Eastern time. I'm on Central, so it gets me a little.
Noon Pacific.
Okay. And then we also have another iteration of this session. It will be a video based discussion about gastric bypass reversal. One of probably the most, one of the most prolific surgeons in our group, Omar Ghanem, will be presenting on that. So that's going to be really, really good. I invite you guys all to come back and bring some friends with you. I also want to, since I'm talking, take this opportunity to thank Dr. Mattar for showing up this evening. And also Dr. Pandit for preparing the slides and going through the discussion, like kind of helping to lead us. And my co-host, Dr. Fisher, and James and the ASMBS team. And all of you guys who showed up. I guess I should just thank everyone. But
I'd just
we're
like
very,
to say thank you so much, Julie. Oh, I'm sorry, I'm interrupting you.
it's okay.
But I really have a fondness for this committee. This was my first committee when I joined ASMBS. I joined the surgical training committee and I rose to become chair. And this was about more than 20 years ago. And we drafted the first curriculum for training in bariatric surgery. And it was the first curriculum that was standardized across all subspecialties. So it's always been very dear to my heart, and you guys continue to do great work because really you're training all our successors, aren't you? And you're maintaining the excellence of this profession that is so fascinating. So thank you for all the work that you do.
Of course.
Thank you so
Thank you.
much. And thank you, Dr. Pandit. That was awesome.
Thank you.
Welcome to all the new fellows. It's not quite the beginning of the year anymore, but you have joined an awesome field and we're really excited to have you as colleagues. And if you need anything this year, please let us know. And if you want to volunteer to host one of our journal clubs or video sessions with us, please email me or Dr. Lloyd or Dr. Pandit or ASMBS, and we will get you signed up for one of our next sessions.
And actually there in the webinar chat, there is a link to the Google form. It literally takes like 2 minutes.
Yeah.
Oh, there you go. ASMBS sent it. So you guys have it right there.
All right. Well, I hope everybody has a wonderful evening. Thank you for joining us.